Hi, everyone, and welcome to the SRHM podcast, which explores new research and emerging trends in the field of sexual and reproductive health and rights, with a focus on using rights-based knowledge for action.
Today, we're exploring one of the most timely and debated topics in reproductive health in the United States, medication abortion, and more specifically, the growing use of misoprostol-only regimens. Amid escalating restrictions on abortion access in the US, people are increasingly turning to alternative pathways for care, including medication abortion by mail or pharmacy pickup. A recent SRHM paper by Dana Johnson, Shruti Ramaswamy, and Rebecca Gompertz investigates the acceptability of misoprostol-only abortion regimens when accessed through mail order or retail pharmacies, drawing on in-depth interviews with people who have used this method. This conversation also aligns with SRHM's current call for papers on ensuring access to abortion as a matter of rights, equity, and justice. We're inviting submissions that explore abortion through legal, social, political, and clinical lenses with a deadline of 31st August 2025. You can find more details in the show notes. I'm delighted to be joined today by the lead author of this important study, Dana Johnson, a research fellow in the Department of Population Health Sciences at the University of Wisconsin-Madison. Dana, thanks for being here, and let's dive in. To start, could you give us a brief overview of your study? What did you set out to learn, and what makes this research especially important right now?
Thanks, Nina. Well, first off, thank you so much to you and your colleagues at the journal for having me. I'm really excited to be here with you and to be having this conversation. So our study focuses on medication abortion used for self-managed medication abortion in the US, and the people in this study used the misoprostol-only regimen. And for medication abortion, the World Health Organization recommends two regimens, either misoprostol used with mifepristone or misoprostol only. And I'll note that both of these regimens are widely recognized as safe and effective. But in the United States, where I live and where most of my research is based, the vast majority of medication abortions are completed using mifepristone and misoprostol. But this is really important because there's a lot of political hostility towards abortion and abortion pills in the United States. Anti-abortion lawmakers and activists have made it pretty much one of their top priorities to limit access to mifepristone. And they've attempted this in a variety of ways. They've been doing this through litigation, through a sham case that went all the way up to the Supreme Court that attempted to revoke the Food and Drug Administration's approval of mifepristone. They try to impose unnecessary restrictions on how providers can dispense mifepristone. And some states have even tried to formally label mifepristone as a controlled substance. So with all of this political focus on mifepristone, we knew from the dearth of global evidence that misoprostol only can be safely and effectively be used by itself for a medication abortion. So my colleagues and I set out to understand what are people's experiences with using misoprostol for abortion in the US. And this was part of a larger safety and effectiveness study on misoprostol only used in the US setting. So the study I'm talking about with you today is focusing on 31 semi-structured in-depth interviews that we conducted with people who self-managed their abortion with misoprostol that they obtained from either a mail-order pharmacy or a retail pharmacy in the United States. And the participants in this study had their abortion between May and June of 2020. And so in our analysis, we really honed in on the acceptability of using misoprostol for medication abortion across three domains. We wanted to look at people's experiences with the regimen, with the mode of service delivery of the meds, and their overall reflections on the model of care. And in summary, we find that participants felt this regimen to be highly acceptable. They had certain perceptions about misoprostol, either from firsthand experience with the drug from prior abortions or miscarriages, or from reading about it online. People also had a lot of contextual familiarity with the pharmacy setting, and they liked picking up their pills at the pharmacy. It felt like it legitimized the process. And overall, people felt like they were very satisfied that they had access to abortion care when they needed it most. And just to answer the last part of your question, the relevancy of these findings in this political moment, I think that these results are super important now because they contribute to this growing body of evidence on the acceptability of misoprostol-only regimens. And as mifepristone continues to be under threat in the United States, as well as other countries throughout the world, this research can inform our strategies for utilizing misoprostol regimen of medication abortions.
Thanks for that comprehensive response. I wanted to turn now to one of the specific findings in your study. So, one of the findings points to a distinct unmet need for emotional support, particularly among adolescent participants. Could you please share more about what these younger participants expressed and what it tells us about how abortion care and post abortion care needs to better support adolescents?
Yes, I'm so happy you asked this question because I think this is one of the key parts of this study, and I'm really happy to talk about it more. So, three of the participants were teenagers at the time of their abortion. And when I was conducting these interviews, they were by far the most intense and meaningful conversations that I had with the participants. All three of these folks described really intense aspects of their lives. They were going to work, they were juggling high school. One person was managing her parents' divorce. Another person had been sexually assaulted by a classmate, and they were in the process of transferring schools, all the while searching for abortion care during a pandemic. And so when they described their experience, there was really this distinct unmet need for emotional support in these conversations that felt like it really stood out compared to the older participants. And this struck me for two reasons. First, I work a lot with a youth-focused abortion fund in the United States called Jane's Due Process. And Jane's Due Process is the only abortion fund in the US specifically dedicated to the needs of teenagers. So the organization has a hotline and a text line where teens can call for access to abortion care, for questions about abortion care, questions about contraception. And this really reminded me of the work at Jane's Due Process because it really is a wraparound organization aimed at specifically supporting the needs of teenagers. And this is key, right? Because teenagers, particularly minors under 18, they exist in this unique legal, social, and political context. And I think that these findings and the work with Jane's Due Process that I'm familiar with remind me that we really need specific and teen-centered support for people and their reproductive needs at this age. The second thing about this that I've been thinking about a lot is that from an academic and a research perspective, there really is very little research on adolescents, especially teenagers, and their experiences with self-managed medication abortion. So globally, there's a good amount of research on adolescents and self-managed abortion. But in the US setting, we really are lacking a lot of information about what teenagers need. So in the US, I want to encourage all of my research colleagues in the field to look at their study designs and to make sure that they're including teenagers, especially minors, that they're including them in their sampling frame, in their surveys, and in their in-depth interviews and focus groups. Because as a research community, we really need a better understanding of the unmet needs of adolescents so that we can tailor supportive interventions for this group.
On that note, your paper focuses on acceptability, a concept that includes more than just clinical outcomes. So, what did your participants say about whether this method is acceptable or not for them? This method referring to using a misoprostol only regime.
Yes. I'm glad you raised this because acceptability is not always even included in clinical studies, right? Sometimes it's maybe one or two survey questions that ask if someone would return for treatment or if they were satisfied with their overall experience with care. But we felt that qualitatively, we really needed to parse out what acceptability meant to people beyond just a single survey measure. And I think that in-depth interviews are really suited for that kind of work. So we found that, first off, individual perceptions of misoprostol were really shaped by people's prior and informed knowledge. And what I mean by that is that some people had prior knowledge from growing up in another country where misoprostol was the primary medication abortion regimen, or they had used misoprostol for a miscarriage or cervical ripening. They had other familiarities with this in the reproductive context. But then other people, they totally informed themselves. I mean, people are incredibly adept at finding information online, and there is a lot more self-managed medication abortion information online now than there used to be. And people were quoting studies back to me in these conversations that shaped their acceptability, how informed they felt and prepared. The other piece was this practicality of the pharmacy. In the US, the pharmacy is one of the main healthcare settings that people interact with, even more so than an emergency room or a primary care doctor. So people felt like the fact that they could pick up these pills at a pharmacy destigmatized the process and fostered familiarity. For those who received the pills by a mail order pharmacy, there were other acceptable aspects to this that they mentioned as well, but primarily it was privacy and anonymity in the abortion process. And then overall, part of our conceptual framework was looking at acceptability as a broad reflection on their experience with care from start to finish. And overall, satisfaction was high across participants, primarily because they were able to have an abortion when they needed it most. And I think that's really, really important because with that, we need to think about people are getting access to care, but how can we make the entire process more comfortable, more acceptable? How can we counsel people on cramping, diarrhea, potentially other negative effects that they might experience during the process, but then also make sure that they overall get access to the care that they need?
Thanks. And that was a really great highlight and overview of kind of key considerations of individuals who want to access this care. But as anyone knows who's been following the news, the legal landscape in the United States is shifting rapidly and unevenly, particularly related to access to abortion services. So, how did the participants in your study navigate concerns around legality, safety, or fear of surveillance, especially when using a mail order or pharmacy pathway?
Yeah. Yeah. And I will note that things have changed a lot since these interviews were conducted in 2020, primarily since the overturning of Roe versus Wade in the United States. It really is quite a different landscape. But I think there are still nuggets in these in-depth interviews that highlight things that people are saying today and that I'm seeing in the conversations I'm having today. But people really navigated the legality and the safety by asking questions. They asked a lot of questions of the people in their life. They asked a lot of questions of the service where they ordered pills. They wanted to make sure that the packaging was discreet. They wanted to make sure that they knew exactly when the package would come in the mail if they used a mail order pharmacy. If they used the in-person pharmacy pickup option, a lot of people said that they navigated this choice to actually use a different pharmacy than they typically might go to. They might have driven a couple miles out of town. They wanted to make sure that especially if they were living in a small town, that they had a private experience going in person to pick it up. And although this wasn't mentioned explicitly in the interviews, I want to highlight that since there is this context of surveillance and legal gray area in the United States around a lot of abortion care, places like If, When, How, Lawyering for Reproductive Justice have a free repro legal hotline that anyone can call at any time with questions about self-managed medication abortion and about abortion care in general. And so I always try to remind folks that If, When, How, Lawyering for Reproductive Justice runs this repro legal hotline precisely so that people can have a safe and accurate place to ask their questions about abortion care.
Thanks, Dana. And, you've highlighted that the legal and policy landscape for abortion has changed so drastically from when you actually conducted the research and when you were analyzing the results. But based on the findings, what changes would you like to see in abortion policy, service delivery, or public health messaging in the US?
This is a great question. First, I think we need to be really serious about the threats to mifepristone and abortion pills in general in the United States. In this country, the US, the Trump presidential administration is extremely hostile to medication abortion access, and they're using a lot of creative levers to limit access and criminalize people seeking care. And although I think the Trump administration grabs a lot of headlines, things that are happening in state legislatures are just as important. This past legislative session, multiple states, including Texas, Louisiana, had bills that were aimed at criminalizing abortion pills sent by mail and abortion pills as a controlled substance. So I really encourage folks who are interested in this to get involved in their state level advocacy and try to see what's happening in terms of medication abortion access and what kind of bills might be curtailing that access. The second thing is that we know misoprostol is a really important medication abortion option. It's a tool that we have in our toolbox for safe and effective access to care. And misoprostol is just an incredibly important medication. It's shelf stable. It is relatively low cost. It is available over the counter in some countries, including Mexico. And it's a really important avenue for people who need access to abortion care. And then the last thing I want to leave listeners with is that we need to think broadly, because the unmet needs are very clear in this research and a lot of the research that my colleagues are doing. Abortion is not the only thing going on in people's lives when we interview them. They are going through housing insecurity, food insecurity. They're navigating violent situations. They're navigating tenuous work schedules. Abortion is just one part of someone's lives. And I want to push policymakers and public health officials who really care about abortion access to also advocate for housing, for SNAP, for Medicaid, and for racial justice, and for these other aligned factors that we are overall seeing an attack on them politically in the United States, but also elsewhere in the world. I really do think to my core that abortion is one part of our participants' life. But if we really want people to live the lives that they want, to build the families that they want, and to truly actualize reproductive autonomy, we need to advocate broadly for health and social justice.
Thank you, Dana, for all of your work and your colleagues' work as well on this study and for sharing such thoughtful insights today. For our listeners, you can read the full paper, Acceptability of Misoprostol-Only Medication Abortion Dispensed by Mail Order or Retail Pharmacy, online and open access at srhmjournal.org or through the link in the show notes. This article is part of SRHM's ongoing commitment to publishing evidence that advances rights-based access to abortion as a matter of rights, equity, and justice. If you're working on these issues, we encourage you to submit your paper to the journal. You can find our current call for papers and submission guidelines in the show notes as well. Thanks so much for listening. Please subscribe and share the podcast to help amplify rights-grounded knowledge and evidence in sexual and reproductive health and rights.
Thanks for joining us for this insightful conversation. Please check the show notes for a link to the SRHM Journal, which is available online and open access. Follow us on social media and sign up for our newsletter to receive notifications for new publications. If you're enjoying this podcast, please subscribe, give us a rating, or leave a review. Sharing evidence-based and rights-grounded knowledge is our passion, and it's also critical to support the advocacy and actions that need to be taken to improve SRHR for all. We would very much appreciate it. Thank you for supporting the SRHM podcast, which is produced by our staff. The music was composed by Tiber Christian and Salomon Beautombe.